in babies, we will fail in breastfeeding. But Madam never agrees to that. I have seen Madam taking classes so passionately that we will forget about lactation failure. There is nothing like lactation failure. We can feed any baby. We have discussed with Madam, and Madam will enlighten us regarding how to feed a difficult baby. That is what we told her to talk about. She has empty number of examples, and we all will be benefited with her wisdom. So I think we can start the program without much delay. Back to Priya for continuing the session.
Thank you, Dr. Riaz. Elizabeth Madam has not yet logged in. And we have seniors with us like VK Parvati Madam, we have Deba Bhaskaran Madam, and many seniors are there with us. And let me introduce to you Dr. Asha Benakappa. She is the HOD of Dr. Chandrama Dayananda Sagar Institute of Medical Education and Research. And she was the former director of Indira Gandhi Institute of Childhood, Bangalore. She was a former HOD of Bangalore Medical College, and she has over 40 years of dedicated. She has dedicated to promoting breastfeeding awareness, and has received over 30 plus awards and felicitations and many publications to her credit. And I think she is the apt person to talk on breastfeeding challenges. Over to you, ma'am.
Thank you very much, Priya, for that crisp and short introduction. At the outset, I would like to thank, first of all, my nutrition guru, Dr. Elizabeth ma'am. And it is so thoughtful of Dr. Riaz to invite all the women force here, okay, the super women as the faculty. And of course, Priya, who's been constantly in touch with me. So let's get started. Let me share my PowerPoint. Okay, I have called this, I have titled this as Transforming Breastfeeding. Close this window. Yeah. 1 minute, we always have this startup issues. Next. Okay,
Madam, it's coming correctly.
It's coming now?
Yes, ma'am. Yes. We can see.
Yes.
Yeah. At the outset, I would like to tell that I had spent 40 years, and it was Dr. Rupal Dalal who fine-tuned my knowledge on breastfeeding. You know, I should say it was very precision and perfection was from Dr. Rupal Dalal. Okay, I would like to start off with some fundamentals of breastfeeding without taking you to all the usual things that we do in any webinar, because Riaz was very, very particular. It's not going to be the usual lackluster webinar. We're going to discuss some serious issues. Okay, so I want all of you to know that there are different positions and latch when it comes to breastfeeding. You have cradle hold, you have laid back, football hold, side lying, cross cradle, Australian hold, many different methods. Every pediatrician must know these techniques. Okay, and I also would like to tell you the whole process of pregnancy, you know, maternal adaptations during pregnancy is all about preparing for neonatal care. It is a remarkable. Can somebody mute that person? It's a remarkable physiological transformation that prepares the mother for successful breastfeeding and bonding. So we just have to flow with the nature. I'm a favorite fan of Dr. Ruth Lawrence and her book Breastfeeding. You must all Read it. And it is very unfortunate that she passed away yesterday. So stressing on different positions which may be required in difficult situations. Please note, it is near to nipples. The upper lip of the baby for wide opening of the mouth. The nares to nipple tickle upper lip of the baby for wide opening of mouth. And the mouth should be opened 128 degrees centigrade. I just want you to know that this is everted. Okay? Many times this does not happen. Chucking the latch is equally important. And the distance, 3 fingers from the base of the nipple is how to hold. Okay, simple way of telling is at 3 o'clock and 9 o'clock positions and 3 fingers. Okay, this is a classic example. Whenever you're eating a big bite of a vada pav, you need to open your mouth wide, your lips are everted, and your hands are beyond the 3 fingers. Okay, so that you can have a bite. I use the example of a banana. You cannot eat a banana when you hold it upright. You have to keep it horizontal, not vertical. Similarly, it is the lips of the baby and the fingers of the mother are parallel to each other. This is the baby's lip and this is the fingers of the mother. And this is Rupal's hand, to teach me. I have learned this skill and perfected it. So it is like a claw. You hold it like that. Next thing is you have to chuck the latch. Please, from this session, you will chuck the latch in every baby. And I want you to note that the the lips are everted, chin is touching the breast, and most of the areola is in the baby's lower part of the areola is completely inside the baby's mouth, a little bit of upper areola, and the nipple and areola have made it a beautiful teeth to touch the soft palate. When the baby's chin is touching the mother's breast, there should not be any issues with feeding, with breathing. Okay, many times mothers put their finger here, pull the nipple away, thinking the baby is not breathing, and therefore, in fact, there is no lactiferous sinuses in the baby's mouth. It's extremely important against to stress removal of fat, rich, and thick hind milk. Okay, it is in the latter part of a feed. I'm just taking this example, but when you tell it to the mother, she gets very confused. If the feed has lasted for 12 minutes, 9 minutes, the baby gets the watery fore milk, and the last 3 minutes, the baby gets the rich hind milk. Extremely important for satisfaction, brain growth, and growth of the baby in length. In the first 3 months, baby grows lengthwise. So how do I make out this hind milk? When I press with 2 fingers. We press from the base of the nipple, I put 2 fingers, I press, compress, and release. Now the milk will come like drops. That is the end of the feed. Mother has to feed on the same breast till she gets that milk. Okay? And I've taken the example of a working mother. Okay? And this is a 32-year-old first timer. All these case scenarios are from my hospital in the last 1 month. A 32-year-old first-time mother, she's a working woman in a corporate sector, returned to work at 8 weeks postpartum. Okay? She faced difficulties due to long office hours and work pressure. So we have to have a before in the last trimester of pregnancy, we have to discuss with her. We have to do a lot of counseling and ask her to use the maternity leave post-delivery. And also we should tell her about the paternity leave. What were her concerns? She had lack of motivation, Most of the families are nuclear, practically no support, risk of decrease in milk supply due to stress, inconsistent feeding. She was all set to switch to formula, lack of knowledge about timely expression and storage of milk. So how did we approach this mother? We built confidence in the mother. We assessed the home and work situation. We gave family support, looked at the family support, discussed about the creche facilities and technique of expression and storage of breast milk. Next, cup feeding of express breast milk. You did all these efforts, and once the breast milk is expressed, she will go and put it in the bottle and feed, then the baby will go for nipple confusion. So every pediatrician must know how to express the breast milk and teach the mother cup feeding. I'm a proponent of manual expression of breast milk and not mechanical pump expression. Okay? When we have time, we can discuss why it is not allowed. There's a beautiful working mothers program. You know, I've written the feeding time 12 days before she reports for work. Start off this program on the first day, that is first, second, and third day. She is at home with the baby and she's thinking that she's going to go for work. So the first feed in the morning will be when she gets up from the bed at 6 a.m. She will feed direct breast milk. Then she'll go and have a bath, etc. Come back and feed, express the breast milk. If she has fed the baby on the right breast, she will express the breast milk from the right till she gets the hind milk. And then she'll move on to the left breast. And that express breast milk at home, she will feed by cup. Mother is there, baby is there, she's at home. We are imagining that she's going to report for work. So we start off with one express breast milk and the rest of it is direct breastfeeding. And I've said 3 days because even to give that one express breast milk, it will take 3 days for her to get used to it. And then day 4, 5, and 6, it becomes 2 EBMs, then 7, 8, 9, like that, so on and so forth. So when she comes home, there is something called as reverse feeding. She'll go on feeding the baby frequently. We advise the mother to report for work on a Friday so that we have Saturday and Sunday, because when she goes for work, we will come to know what are the issues she had, and those issues can be addressed. And while at workplace, she goes on expressing the milk, puts it in the ice pack, brings it home, and puts it in the refrigerator for use next day. Okay. We also have to ensure that the breast is emptied every 3 hours. Otherwise, feedback inhibitor of lactation is produced. Next, we have to teach her the 4-4-4 rule. We have to teach her how to store the milk, refrigerator for 4 days, and then, up to 4 days, then freezer, then label the containers and use food grade glass or plastic with tight fitting lids. Thawed milk, once thawed, use within 1 to 2 hours. After feeding, if the breast milk is left, it should be used within 2 hours or discarded. Because when you're feeding, some of the bacteria from the baby's mouth may get into that milk and it will grow in it. Therefore, you will have to ensure that the milk is thrown away after 2 hours if it is not used. Then we as pediatricians must tell, this is at least in the organized sector, there are so many maternity benefit acts, starting from Pradhana Mantri Matritva, Matruvandana Yojana, Maternal Benefit Act of 2017, and Samadhana application, breastfeeding friendly workplace. It's we have to have, if the women employees exceed around 40%, it's a mandatory that they have a breastfeeding workplace, creche, place to express, refrigerator, etc. And they should be oriented during pregnancy to go to a hospital that is breastfeeding friendly hospital initiative. It is also our duty to tell them about the infant milk substitute, infant food, and feeding bottle act, because they are easily converting into, it's very easy to shift off to a formula and they will not be knowing anything about it. Now I would like to take a second case, okay? And I think I'll finish and you can ask doubts at the end. I leave it to you. Should we discuss here, Dr. Riaz and Priya, or shall I continue? Yes?
Please continue, madam. Continue.
Okay. Okay. This is a 29-year-old mother with chronic atopic dermatitis, presented to us 1 month postpartum with cracked, weeping, eczematous lesion over both areola, causing severe pain and fear of infection. Local lesions was very discomfort. Breastfeeding was painful because she was only hardly doing any breastfeeding. Fear of infecting the baby, and we were worried about her stopping direct breastfeeding. These were the lesions. What did we do? We reassured her, motivated her to feed directly, and the local lesions were treated, and hygiene and other supportive care. I started off with different feeding positions. If the lesion is on the right upper quadrant, then you position the baby in cross cradle, or you can position the baby in upright position, or it is called the bear hold or cola hold. Okay, so that was the reason why I said you must be aware of different positions. This mother successfully breastfed wonderfully well. Case 3, a 27-year-old woman, 3 weeks postpartum, presents with pain, swelling, and redness in her right breast for 4 days. She reported fever, malaise, all features of a breast abscess. She has breastfeeding exclusively, but finds feeding on the right side extremely painful. Okay, we are all right-sided. We find it very easy to feed the baby on our left breast. I don't think you can see the vision anyway. So it is a common phenomenon that happens, and we have to teach her how to do. One thing I have noticed, in a breast abscess, usually people will tell us stop breastfeeding on the affected breast. Remember, when she's feeding on the unaffected breast, milk production continues on the affected breast and causes a lot of issues. Either the affected breast you should express and throw the milk if you're very worried, but do not say don't feed or remove milk from the affected breast. So she has a localized lump in upper outer quadrant of right breast. It is red, warm, and tender. Irregular feeding, fear of infecting the baby. Should we do surgery or conservative management? So we built the confidence in the mother. There was no contraindication to feed on affected side. We did direct breastfeeding on both sides, warm compression to stimulate oxytocin reflex, cold compression after feed to reduce edema. And I believe in a big bore needle aspiration rather than incision and drainage. Can you see the lip of the baby is everted? And so beautifully, this is the drained one. Baby is feeding, and within 3 days, all problems settled. I would like to again emphasize the garment that the women wear. We need a free access to the breast, not tight-fitting bras, etc. So the next case, 24-year-old mother diagnosed with HIV, delivered by cesarean section. So she herself was malnourished. She had a lot of guilt. We had to spend a lot of time with that mother to overcome her guilt, depression, her nutritional status, and she was very, very concerned about HIV transmission to baby. Remember that all mothers, even if they are severely malnourished, they can give very good quality of milk up to 6 months. But the fat, if the breast milk contains about 3.5 grams of fat, but it may contain 3.1 gram. So just because she's malnourished, people say don't breastfeed because you will become further malnourished. So take care of a nutrition, hydration, antiretroviral therapy, but there is absolutely no issues with breastfeeding. So support mother and family while maintaining confidentiality. We counseled her nutrition, antiretroviral therapy, exclusive and direct breastfeeding, ART prophylaxis for baby till early infant diagnosis. This was a very tough case. A 26-year-old primey with bilateral true inverted nipples, struggling with baby's inability to latch. She was guilty. So we always address their concerns. Okay? If that concern is not addressed, then she will not be receptive to what you're telling. Okay? So what did we do? We really struggled. I really pray and hope the video works. It is perseverance, persistence, patience, and commitment. We say it's a good bite of the breast tissue. Okay, we kept giving the baby a good bite of the breast tissue. And every time she needed assistance, meaning every 2 hours, and in 48 hours, the so-called true inverted, can you see that? Baby is feeding so beautifully. It's a truly retracted nipple. And now the baby will start feeding because we believe in a good bite of the breast tissue. I must confess, I hope you can see my hand there. It was an extremely difficult situation, but we did manage. Okay. And again, check the latch. I'm checking the latch there. So how did we approach? It was reassurance, persistence, direct breastfeeding, different feeding positions. There is something called as Asha Benakappa technique. We'll just see how much time we have. I'm not for this. Okay, this is the last resort. I've put up this picture here to tell you that this is not required anymore. All books have this. Again, we have this baby with the cleft lip and palate and difficult latching, and all the people around were telling her that the baby will choke and die. At the first place, the mother was heartbroken that she got a baby like this because she had dreamt of a beautiful creation. But this happened, and not knowing how to feed, because we say milk overflow syndrome. In the first 24 to 40 years, milk is just pouring out. The child, if not properly latched, will choke. And here is this video. Okay, you can watch. I don't know, the video is longitudinally stretched. I hope you could see that the baby was latching. Reassurance, demonstration using dolls and models. Show this video. We tried different position, deep latch, use of breast tissue, the upper part where the baby's mouth goes in. The cleft lip and palate is covered by the breast tissue, and it works like the applicators they use for at a later date for the cleft palate. Okay, surgical correction. Then there's a 22-year-old mother with primey who had delivered twins, and she had an NICU stay for 2 days. And worry was about insufficient milk. And she said, "No, how can I feed 2 babies?" I always say each mother can feed triplets, quadruplets too. So we have to reassure. I believe in simultaneous feeding of both babies, one breast for one baby. Please show different positions. Again, you must have dolls and models of breast. Even triplets, I just now told you, and quadruplets also can be breastfed. Again here, this is a video of a mother who came to our hospital. So if one baby is breastfeeding on one side, the other baby, if it is a weaker baby, the breastfeeding twin will help the other twin for easy flow of milk. Okay, this is a beautiful position, but initially she needs support from some family member to hold the baby. This is the other babies crying in the ward. Okay. So this pictures are available only in my book. I really don't know from where I got them. So breastfeeding twins, I showed you one position. I'd shown you this position. You can put the baby in any position, okay? And see that the nipple and areola are inside the baby's mouth. Lips are parallel to the fingers of the mother. Once she has lacked the baby, she can remove the fingers. This is a 31-year-old mother gave birth to a baby weighing 800 grams, feeding an extreme preterm, prolonged NICU stay, and again, lack of knowledge about expression and the not enough milk syndrome. We built confidence, taught her expression of breast milk, especially hind milk feeding. Okay, and orogastric tube feeding in NICU. We counseled her regarding evolution in NICU, feeding evolution in NICU, hind milk feeding, and deep latching. One of Dr. Rupal Dalal's student came and stayed with us for 1 month, and she was very fascinated because she's basically a nutritionist. She spent 1 week in the NICU and she was very, very focused about hind milk feeding, and she used to chuck the weight, and she was telling me, I have never seen this miracle. Okay. So this is a story of a mother whom I personally attended when I was the director of Indira Gandhi. And this was a baby who was 800 grams. And if you look at the textbook of neonatology, where he says even 0.5 ml of milk, trophic maternal breast milk in the first hour of birth, immature babies facilitate the colonization of nave gut with normal bacteria. Robertson's textbook of neonatology. So we must know, because in these babies, we can't do nasogastric feeding. We must know orogastric. First, you must know expression of breast milk. Second, in the NICU, we do orogastric feeding. This is called gavage feeding. You're not pressing the piston at all. And after expression, you must learn how to do cup feeding. Okay, all this should be taught in the NICU itself. Express breast milk, we do cup feeding. You may ask me why? Because the baby will not be able to effectively do the milk transfer, and there are other issues. Okay, so that express breast milk, we gave the baby orogastric. Now we are giving the baby by cup feeding. You just have to tilt the cup with a projection like that. The baby is happily feeding. He himself is drawing the milk towards the, see, not even a drop of milk is being wasted. You need a little bit of smaller cup. Okay, these are all my personal videos done over the years. This is a baby outborn, mixed feeding. Definitely the mother will complain of decreased milk. The breast milk should be removed every 2 hours in the first 6 weeks. Subsequently, it is every 3 hours. If you don't do that, then we are not stimulating milk production. Oxytocin reflex pushes the milk out. Prolactin at the back, when the baby is feeding now, at the back, prolactin is produced for production of milk. It is a continuous process. When you have given mixed feeding, when you have given animal or a formula milk, then they are designed to be emptied after 4 hours. By then, if the baby is less than 6 weeks, by 2 hours, there is FIL, we call it, feedback inhibitor of lactation is produced. And then after 6 weeks, it is 3 hours. And this suppresses the milk. Plus, how did you give the feeding? Did you give it by cup, bottle, and all that? So we land up with a situation called nipple confusion, which I label it as malignant condition. And there will be decreased milk secretion, definitely. So appreciate the mother, phase out top feeding, from bottle shift to cup and direct breastfeeding, frequent breastfeeding, relactation attempts with different position, and you must teach the mother about expression and storage. Recently during our nutrition in pediatric clinical course, one of the former student was telling that oxytocin environment, she did not know about it. There is a lot of science behind skin to skin contact. Delay the cord clamping, put the baby on the mother's abdomen, let the baby crawl towards the breast. And remember, nipple and areola are hyperpigmented in the last trimester of pregnancy, and the baby is guided towards its source of nutrition. So when you put the baby on skin to skin contact, if there are PGs here, skin to skin contact is different from kangaroo mother care. This is done in normal babies. Kangaroo mother care is continuous, and we do it for preterm babies. So oxytocin is released, dopamine is released, stress hormone is reduced. Look at that fascinating thing, just by skin to skin contact. This is called as oxytocin driven environment. And all the people who are friends of breastfeeding, we have a group of friends across the globe. We call ourselves as breast friends. If you create such an environment, it would happen very well. I've deliberately put this picture. Oxytocin is also called as cuddle hormone or love hormone. Whenever we hug anybody, we're actually doing the oxytocin massage at the interscapular area, from the nape of the neck to the interscapular area. And even when we are holding the baby, if you can just imagine, I'm not able to show you on the doll, you are actually, the back of the baby is touching your forearm, and that is also helping in oxytocin release and oxytocin reflex and oxytocin conducive environment. What are the physical methods to increase breast milk supply? From kangaroo mother care, it is skin to skin contact. To help let down reflex, you must smell the baby's clothes, listen to music, have his picture on the mobile for those working mothers, or a record is, good, all his baby language. Listen to it. You'll have oxytocin, and you'll start feeling the milk production. Hot water fermentation, massage of upper neck, back and breast, correct clutching and positioning, gentle pressing of the breast, very, very important to emphasize on nighttime feeding. Baby can sleep next to the mother. Okay, it is bedding in, cotting in, blanketing in. If the baby, we only don't advise the mother to sleep and feed if the baby is less than 1.8 kgs. All of the babies the mother can breastfeed. And if active breastfeeding and hind milk is going on, baby will gain 30 to 90 grams per day. You have a 1.8 kg baby. In 10 days, the baby will gain 600. In no time, the baby will reach 2 kgs. Breastfeeding frequently is extremely important. Hind milk feeding, expression of milk, breast milk, and removing breast milk frequently if you are not able to feed the baby immediately. So this is a known case of Conn's disease we had, medications. We're very worried about mothers who are taking medications and breastfeeding. We must look at the product label, look at the half-life. If the half-life of the drug is 4 hours, so when I'm feeding at 8 a.m., I'm doing direct breastfeeding. At 12 noon, that is 4 hours, most of the drug is there in my breast milk. So what do? I express and throw the milk and then put the baby back to the breast. Despite warnings on the label, just check the half-life, and accordingly, you can feed the baby. There are hardly any exceptions to breastfeeding, exceptions to breastfeeding and medications. So reassurance, except anti-cancer drugs, a woman who has got cancer would not conceive and get into breast milk production and all, breastfeeding. But even then, you look at this half-life, okay? fixing schedule for medications, keeping half-life in baby, exclusive breastfeeding like any other mother and baby. So I just want to stress that not enough milk is a universal phenomenon. Universally, all mothers secrete milk enough for 2 or more babies. Okay. This is a postpartum mother presents at 2nd week after delivery. We wanted to make it like a quiz in between, but I think I'll finish off. She had an extremely painful latch. It's a very, very rare case. And this baby had a very tethered tongue, I must call. A deep tongue tie, which is tethered. So the baby was literally feeding on the gums. So while the baby recovers from surgery, the mother can express the breast milk and keep up her milk supply while the baby surgery is done. Exceptional. This is very, very rare. Okay. Then another mother, normal vaginal delivery, both breasts enlarged and firm, etc. Again, the same situation. We say when the baby is not put to breast immediately after birth, you go through different phases. Okay. First, the breast is very soft and supple so that you can navigate the nipple into the breast into the baby's mouth and give a perfect latch. But as at the end of 48 hours, the breasts become full, and that is called full breast. So bilaterally full breast, when you can express the milk, then it is full breast. Then the full breast will go for engorgement, difficult to express. It happens bilaterally. Then you'll go for mastitis. Mastitis is a phenomenon where you feel the breasts are implanted. Okay, so please, putting the baby to the breast within 1 hour of birth gains lot of significance. Okay, 2 weeks concerned with her milk, baby is exclusively breastfed, 6 diapers, and is gaining 35 grams per day. Okay, and because the baby cries frequently. Here we teach the mother about hunger cues. This is one of the 2009, this particular picture won a global award for me. I have named this mother as Stella. She was a victim of domestic violence, and she had heard my talk in one of the garment factories. She was determined to breastfeed. And during the last trimester of pregnancy, her husband threw kerosene and burnt her up. She ensured that she protected her breasts because she had heard so much about me and she wanted to breastfeed. She landed up in Vanivilas Hospital, my former institution, and we ensured whichever part of her body we touch, the skin was scraping off. But she said, "Doctor, don't worry, put my baby to the breast," because that's what you told me. And the baby, her confidence, everything was so much that the baby happily breastfed. And it is very, very nice to know that this little boy has become a pediatrician and they live in London now. So breastfeeding is a confidence trick and it needs enormous counseling skills and patience. I really missed Ruth Lawrence yesterday when I heard about her death. This is what her book says. All babies are not going to listen. You start breastfeeding, stop breastfeeding. No, it is not one fit for all babies. Okay. They put their signature styles by grabbing the nipple and sucking energetically. They are called as barracuda. They're excited ineffectiveness. There is procrastination. There is gourmet. They can taste the little drop of milk before they actually latch on. Then resters, prefers to nurse for a few minutes, then rest for a few minutes, resulting in longer than nursing time. You'll be surprised to know that the vision of the baby is 20 to 200 or 20 to 400 because he should do focused breastfeeding. But now that I've moved into adult nutrition, I keep saying when you are having your food, be focused. Don't do webinars and sit and eat, drink. Okay. That mindful eating is also extremely important. That is why the creator made our babies have only that much vision so that is focused only on the breast and he breastfeeds. Remember, breastfeeding problems are solved by fixing breastfeeding, not by replacing it. Here is my colleague, Dr. Raksha. We are teaching this mother who had gained excess weight gain. however we tried to push the baby got pushed out. She had huge breasts. We managed to feed this baby for about 3 months, but this mother was not all that committed. She gave up. And here is a mother who came to our hospital to deliver in our hospital because she wanted to breastfeed the baby, met with an accident. Her hand was amputated while section was being done. And that's me sitting with her. She happily breastfed. She's so committed, and she continued to breastfeed prosthesis. So it is, you just don't replace breastfeeding. There is always a way for it. And I would like to acknowledge Dr. Rupal Dalal, maternal, infant, and young nutrition, early childhood, and all that. And then Dr. Varsha Mahadevaya, my senior resident in MBBS. And of course, my daughter-in-law, who's not put her name, Mrs. Sonika Adarsh. Dr. Riaz has met her. So I'll end this and keep the podium open for questions. Thank you. I want all of you to take a screenshot of this QR code, and whatever I have told, it is available in many languages. It is very, very easy for the mothers to understand this. So you can sit with them. Many of them have a smartphone. Take a screenshot, teach them how to open it. And when they open it, you tell them how to see it. From maternal, infant, and young child nutrition, a little bit of adult nutrition is also there. It's worthwhile. I have flooded my hospital with all these QR codes in various places. And I've also made a booklet which is kept in various places where students, anybody can access it. When the parents are sitting in the OPD for my immunization clinic, they'll be constantly looking at the mobile. I make them and take them near the QR code. I make them take a screenshot, open it up, and I say, please learn. Instead of going on spreading wrong messages, especially the super moms. I call the grandparents of these children as super moms and super gods. My God, the kind of dictating they do with their myths and misconceptions. Okay, thank you very much. And again, I acknowledge all of you for giving me this opportunity.
Thank you, madam. Thank you very much for that excellent talk with beautiful videos and very beautiful pictures and slides. Thank you very much, madam. And first of all, I would like to know the Asha Benakappa technique you were talking about.
This, in birth asphyxia mothers, okay, I have to come back to the screen. How do I get Sonika? It is, I use a number 5 infant feeding tube. Can you hear me?
Okay. Yes, madam.
Okay, how do I get back to the... I use number 5 infant feeding tube. Okay, this is especially useful in birth asphyxia babies, extremely bad babies, very difficult problem you are having. And during that time, you can put the infant feeding tube as 2 holes, eyes, isn't it? So you occlude the hole posterior, keep the hole in front intact, and strap it to the nipple and areola, and take it in the mother's, give it in the mother's hand, express the breast milk, take it in a syringe and push it through that till the baby's gently, and put the baby's mouth near this. It's been published in Indian Academy of Pediatrics. I'll share it. This is called as new lactate technique. Just a minute. I'm not able to get into the screen. Sonika, screen out. Screen mugito. I have to get it to the Zoom. Yeah, Priya, can you see this? Can you people see the doll? Can you see the
no,
doll?
Madam. Yes, yes, madam.
Okay.
Yes.
So
yes.
what you do know, this is baby's mouth, etc. We take an infant feeding tube. Okay, this is the breast, right? Can you see this?
Okay.
Okay,
Yes, madam.
we strap the infant feeding tube as if it is a lactiferous sinus, right? The infant feeding tube is number 5, and it has got 2 holes at the tip, right? So that it doesn't get blocked. So the front hole of the infant feeding tube, keep it as it is. Okay. The back hole, just cover it with a plaster. Then you attach from here horizontal strips, and the other end of the tube comes into the mother's hand, because we have to teach her. It takes long time. So express breast milk in the syringe, fix it to the infant feeding tube, just press like this gently while the baby's mouth is latched to the breast. You have to forcefully latch it. So this works very well in birth asphyxia babies and very difficult to latch babies, etc. And gently do that. So the milk, as if it is flowing from the breast, naturally it will go and it will tickle the soft palate. And as the baby is swallowing, even this milk, okay? The other, in Ruth Lawrence and all those books, they call it lactate supplementators. It is similar to that, but I started even before people thought about all this. Am I clear?
Okay, madam. Okay. Thank you very much, madam. Any doubts? Any suggestions?
Somebody is asking, kindly repeat feeding in inverted nipples. Okay. This is, I will remove. Imagine you must have a doll like this, breast model like this. Okay, this is the inverted nipple. Can you see? Can you see that there is an inverted nipple?
Madam. Yes, madam.
Can you see that? So the inverted nipple, baby is like this. I ensure that the baby is latched like this. Okay. And then you will attach it. Okay, you'll attach it like this. I don't mind going back and showing that video again. You will attach it like that and keep on helping. At the end of 4 or 5 feet, the so-called retracted nipple, which is under the effect of progesterone, will become protractile. You need a lot of patience. So 3 fingers beyond, you put your hand, because we say breast tissue and not the nipple. Okay, then you put it inside, and as the baby sucks it out, it happens. In some of the worst situations, I've used a wall-mounted suction apparatus with a resuscitation mask. We have that resuscitation mask, premature, fix it, pull it out. Okay, these are some of my own techniques, improvised techniques.
Thank you so much, madam. Any doubts? Parvati, madam. VK Parvati, madam.
Yes. It was an excellent talk, madam, and really great talk.
Yes, so there is no situation where a mother can never breastfeed.
Yes, I always think so.
Yeah, and I always keep saying that there is
nothing like
lactation
not
failure.
able to feed or not having enough milk.
Yeah,
that's all.
Yeah,
and of course, it is the persons around who give a negative impact. That's the most important.
Yeah, take the mother into confidence, and
most often the mothers have confidence, but the others, especially the in-laws, put in the problem.
No, but of late, I'm finding a lot of difficulty, because most of the women come from nuclear family. The working mothers, their partners, especially I'm working in the rural part of Karnataka, in Ramnagar district, their partners are not conducive. They don't have that role. They don't think that role of putting the baby to the breast is partnering. That's why in the organized sector, let's use the paternity leave, maternity leave, everything. In the unorganized sector, I find a lot of uphill tasks, especially when the mother comes with difficulties.
Thank you, madam.
So any questions? There are not many questions in the chat box.
Somebody has asked a question, inverted nipple, should it be corrected in antenatal period? No, because the moment you touch the nipple, there will be oxytocin reflex. There may be premature contractions. Okay, but make a note of it and see that as soon as the mother delivers, no, the breast is very, very soft, you know, and that's what makes them think there is no milk. So you work on it within 48 hours. As the progesterone level comes down, the protracted nipple will come out. A retracted nipple will project out. And the baby's sucking reflex is 150 centimeters of water pressure. It just comes out. Baby can suck it out. So, you make a note, see that a senior person, trained person attend this, and then it should not be an issue at all. No nipple shields and no nipple pullers. No. Then about cholesterol harvesting, these are all fancy terms. Cholesterol harvesting, cholesterol mouth paint and all that. I mean, new terminologies will make the youngsters use it, but you have to put the baby to the breast so that he gets the cholesterol. I don't believe in breast pump. I just now said it is, you know, this is a very strong model. It is two fingers at the base of the areola, thumb and index finger, PCR, press, compress and release. Why breast pump should not be used? Because it is not one size that fits all. And once you start using breast pump, insufficient emptying of the breast, milk stasis, message goes to the brain, there is enough milk, and milk suppression. At one point of time, we were thinking in the IMS Act, we said no feeding bottles and no dummies, you know, the pacifiers. We should also include breast pumps and nipple shields. Okay, absolutely no role, please. I had a case scenario of a mother who had used nipple shield and what all she went through. Dr. Rupal Dalal had put it up in the infant and young child feeding group where the mother has sent messages to her in X, I think. Okay, so please, no breast pump, no nipple shields, everything is natural. Please find time to read about maternal adoptions, pregnancy and breast. You know, you have this fascinating called Montgomery glands. Okay, it contains lot of pheromones. It contains anti-infective properties. It gives a fabulous scent for the baby. You know, it's very, very fascinating. Since Dr. Riaz had told me the science we know, we want to know the skill. So, perfect knowledge of milk transfer. You know, the skill of milk transfer should be taught to everybody. Okay, so that's very, very crucial. Very easy, and it is latching, chucking the latch. Mother giving baby for adoption on day 7. Yeah, it's all little complicated. Adopted mothers, surrogate babies, etc. She can breastfeed till day 7. Let the baby get that, you know, nice lining for the gastrointestinal tract, the colostrum, the microbiome, and all that. And then subsequently, if she has handed over the baby for that, then we'll think of alternate methods of breastfeeding. We say more mother's own milk, then is the human pasteurized donor human milk. And then we come for the animal milk. In the animal milk, it is the high fat milk. This is a concept which I learned again from Dr. Rupal Dalal. Because that fat is required for brain growth. Brain is full of fat and length of the baby. Okay. And as far as this mother is concerned, milk suppression is by wearing very tight, like the kangaroo mother care pouch. She'll have to wear very tight things and suppress the milk. I don't believe in drugs also.
Thank you, madam.
Dr.
Anuradha, madam.
Yeah.
Please. Please unmute, madam. Unmute and talk. Madam, we can't hear you.
Now can you hear me?
Yeah, now we can hear you, Anuradha.
Okay. Yeah. Good evening. I'm a very close friend and college mate of Dr. Asha. I practice obstetrics and I'm very fanatic about breastfeeding. And in the starting of my practice, I called up Dr. Shivananda and said, sir, by the time I finish section and come out, the pediatrician would have already advised top milk, and baby will refuse to suck. Then he said, no, of course, he guided me. So to this day, Dr. Asha, I make sure that the baby, irrespective of whether it's section or normal delivery, breastfeeding is taken care. And with respect to retracted nipple, the 5 ml syringe you cut and reverse insertion, it helps us to avert the nipple, and it makes things easier.
I did show you that picture, and that is not accepted now.
Okay, the syringe.
Yeah, I showed that picture. No, I deliberately put that picture because all textbooks and all that, they have it, but we're not supposed to do it. All you're supposed to do it is give a good bite of the breast tissue.
That works. That works.
It works, but it causes a lot of other issues. So it is not recommended anymore. So when I am talking on a podium like this, I should not talk about things that are not recommended.
No, I meant without the syringe, the technique that you suggested works, but it needs a lot of patience and perseverance.
No, the case which I told, Dr. Riaz wanted me to put up very, very difficult situations. This was an extremely difficult case. Too much of retracted nipple. It was a true retracted nipple. Okay, when you do an ultrasound, you can see that it is reversely tethered. Most of those so-called retracted nipples are very easy. They become protractile in 48 hours. It is in that first 48 hours, you give a good bite of the breast tissue. Okay.
Yeah, thank you.
Yeah.
Thank you, Anuradha madam. Actually, we are honored by your presence. Obstetricians.
Yeah, I am the odd man out here.
Thank you, ma'am. Dr. Riaz?
Actually, I think we have got a lot of information and wisdom from Madam. And we can even contact Madam, like when we face the difficult situation. She's always ready to help. And actually, Madam is part of a nutrition program where there is a faculty program where there is a special emphasis on breastfeeding and infant feeding. So continue to enlighten us, Madam. Thank you for Elizabeth Madam. We miss you, Priya. Madam.
Elizabeth Madam എന്താണെന്ന് അറിഞ്ഞൂടാ. Madam കേറിയില്ല. ഞാൻ ഇതൊക്കെ അയച്ചു കൊടുത്തായിരുന്നു.
She must be busy in her clinic. Anyway, thank you. Thank you very much.
Maybe.
Okay.
Thank you very much.
Those celebrating Deepavali, happy Deepavali festivities.
Happy Diwali, Madam.
Yeah, thank you. Okay.
Thank you very much, Madam, for a very, very enlightening talk. And I think if PGs are there around, and if any of the PGs have missed this session, it is very important that they hear the recorded part. And we have a recording too, Madam. I think we should hear this repeatedly and see all these pictures and models.
Especially
it should be seen repeated.
Yeah, especially the videos. Okay.
Yes.
As far as breastfeeding is concerned in cesarean section mothers, I do it off in the OT itself. I wanted to keep at least 10-15 minutes for discussion. So I didn't I have so many case scenarios and personal experiences. Okay.
Thank you.
Thank you very much. Okay, bye.
And I also thank all those who were present here. And really, I should thank Dr. Riaz also.
Yeah. Okay.
Thank you.